I'm Dr. Sarah Hallberg, and I'm glad to be with you here today. We are going to go through pretty quickly some discussion today about why you are actually not what you eat. Let's go ahead and get started. Here are my disclosures. And first we're going to talk a little bit about plasma saturated fats. And there's quite a bit of evidence that plasma saturated fat elevation is a bad thing. It is associated with predicting diabetes and other metabolic disease. It's also associated with increased risk for cardiovascular disease. And you can see here a number of studies looking at it as being a predictor of diabetes. So many people for years have therefore said, well, okay, plasma saturated fat comes from what else? Increased consumption of saturated fat, because the old adage has been, you are what you eat. Well, I'm going to show you here a number of studies that say that is actually not the case. So first is this great study by Dr. Brittany Volk and colleagues from PLOS One. And what this study did is it looked at men and women who had metabolic syndrome, and this was a feeding study. So they were given all of the food over the 18-week study period. And this study was broken up into 3-week blocks. So each 3 weeks, what they were being fed, the macronutrient content of what they were being fed changed. Starting at C1 over on the left, where the carbohydrate content was quite low, but the saturated fat content, as you can see, was quite high. Now, every 3 weeks, what would happen is the saturated fat consumed amount would go down and the carbohydrate consumed would go up until we reach C6 here, which you can see has a much lower saturated fat content, but a much higher carbohydrate intake. So what happened? Well, let's take a look here. Again, C1, which is the lower carbohydrate, high saturated fat feeding period, and C6 on the right, once again, the very high carbohydrate, much lower saturated fat intake feeding period. What happened? And what we can see really more than anything is what didn't happen. What didn't happen is that the saturated fat levels were much higher with the high saturated fat feeding period. If anything, they were lower with the higher intakes of saturated fat. But certainly we can say that they did not increase during that feeding period. And it doesn't matter if we were looking at triglyceride fatty acids, cholesterol ester fatty acids, or phospholipid fatty acids. Same thing. They were no higher with the very high levels of saturated fat. So what was significantly different? And this is really important and something that is not discussed very frequently. And that is with the very high levels of consumed saturated fat, we saw a significant decrease in the palmitoleic acid. That's 16:1. Now, palmitoleic acid is a monounsaturated fatty acid, but it is also associated with a whole host of metabolic disease issues, including obesity. And we're going to learn more about that coming up. Let's take a look at another study. This was by Dr. Jeff Volek and colleagues, and this was a randomized controlled trial, and it had 2 arms. Arm number 1 was a low-fat diet. Arm number 2 was a low carbohydrate diet. Now, as you can see, the caloric intake of both arms were about the same. But as you can see from the pie charts at the bottom, the macronutrient split was very different. And so was the saturated fat content. In fact, in the low carbohydrate arm, they had 3 times the amount of saturated fat as the low fat arm. And so what happened after this study period? And what we can see is that the change in serum saturated fat levels was significantly decreased in the carb-restricted diet arm. So that was both in triglycerides and cholesterol esters. The fatty acids in those, the amount that were saturated fats, dropped with the carb-restricted, high-consumed saturated fat arm. And what we can also see is, taking a look here at what I'm going to discuss with you, is a very important marker in predicting metabolic disease and other issues, which is palmitoleic acid. And once again, what we see is with the high consumed saturated fat arm, we had a significant decrease in the palmitoleic acid levels. Next, we're going to take another look at a study by Dr. Jeff Volek. And this takes a look at 3 arms. It was a randomized crossover trial. It took a look at a habitual diet, a calorie-restricted high saturated fat diet, and a calorie-restricted high unsaturated fat diet. And as we can see here, taking a look at the saturated fat levels consumed, there was a significant difference. The high saturated fat diet arm had over twice as much as the habitual diet, and almost twice as much saturated fats as the carb-restricted high unsaturated fat diet. So what are the results here? Well, as you can see, this is taking a look at the plasma saturated fats as a percent of total fatty acids. And what we see is that the carb-restricted high unsaturated fat diet arm was significantly lower than the other 2. But if we take a look here at the total, what we see, very interestingly, is that both the carb-restricted diets were significantly lower than the habitual or baseline diet. So both decreased when we're looking at total amount. One more important point, once again, is taking a look at the palmitoleic acid levels. And once again, what we see is, compared to the habitual diet, both carb-restricted arms, regardless of the saturated fat content of them, dropped and saw a decrease again in the serum palmitoleic acid levels. In this case, I'm sorry, it was plasma. One more study, and this study takes a look at what happens when weight stays the same. So this was a really interesting study that compared 3 groups or 3 arms, a randomized crossover trial of patients who had metabolic syndrome, consuming either a low carb, a moderate carb, or a high carb intake. And once again, I want to point out how different the saturated fat levels were in the 3 arms. They were all the way up at 100 grams a day in the low carb arm, 70 grams in the moderate carb, and they were down to 40 grams of saturated fat in the high carb arm. Each of these feeding period was a month long with washout between. And these patients, again, were obese at baseline and all had a diagnosis of metabolic syndrome. Now, I'm not showing this, but just to mention briefly that there was a significant reversal of metabolic syndrome in the low carbohydrate arm. But in this, we're more interested in what happened with the levels of saturated fatty acid. And what we can see here is they actually dropped more in the low carb arm compared especially to the high carb arm. You can see that here, whether it was in the phospholipids or the triglycerides up in A and B. But now I want to again draw your attention to C and D as well. So this takes a look at the 16 and 1 again, sorry about that, palmitoleic acid in C and D. And once again, we see, again, consistent, let's see, with all these studies, a significant decrease in palmitoleic acid in the carbohydrate restricted arm. So what we see really, all of this boiling down to, is that we don't consume carbohydrates or saturated fats alone as a general rule. They are part of what we would call a dietary matrix. So you consume some carbohydrates, some saturated fat, they go in, and the saturated fat determination, or where it ends up, if you will, is really what matters is the context of the carbohydrates consumed with it. So when saturated fats are consumed in a matrix with the background of a high carbohydrate intake, what we see is that we see an increase in plasma saturated fats, an increase in palmitoleic or 16-1, insulin resistance, and dyslipidemia. However, if we have even a very high level of saturated fat consumption, but it's in the background of a matrix with restricted carbohydrates, what we see is actually increased saturated fat oxidation, decreased synthesis, and so we have a decrease in the plasma saturated fat levels and a decrease in palmitoleic acid levels as well. That brings about insulin sensitivity and normal lipemia. All right, so the path dependence is really, again, what are the saturated fats being consumed with? That is a key question to ask, and ask we shall. Let's take a look at this study that was very recently published, and it takes a look at hepatic saturated fatty acid fraction associated with de novo lipogenesis and hepatic insulin resistance. So in the past, they have had to actually do a liver biopsy to get an idea of what the hepatic saturated fat content was like, which again is very difficult to do in a research setting. But here, and within this study, they also validated their procedures. They were able to get a look through imaging at what type of fatty acids were in the liver. And what we can see here again is that saturated fat levels were very associated with de novo lipogenesis. So the higher the de novo lipogenesis occurring, the higher the hepatic saturated fat levels. And, so let's pause for a minute, and most people can understand. We'll point it out in just a minute here. De novo lipogenesis, of course, that doesn't come from high levels of fat consumption. That comes with high levels of carbohydrate consumption. But not only that, what we see is that the higher the hepatic saturated fat levels, the more insulin resistant the liver. Or as shown here, what we are really looking at is the lower the insulin sensitivity in the liver. So once again, high liver saturated fat levels led to a decrease in insulin sensitivity, an increase, therefore, in hepatic insulin resistance. So let's take a closer look at that de novo lipogenesis. This was a study from way back in the 90s, and it took a look at healthy men, 4 days of overfeeding of carbohydrates, pretty significantly, as you can see. And so let's take a look at both, again, the saturated fat levels and the palmitoleic acid levels. So what we see is that there was significant increase in the percentage of saturated fat in triglycerides at the end of the 4-day overfeeding period. But take a look at the one on the right. I mean, a massive increase in the level of palmitoleic acid as well. And this is, again, overfeeding for only 4 days. Once again, de novo lipogenesis, significant de novo lipogenesis, and that is causing increased levels, again, of serum saturated fat and serum palmitoleic acid levels. So now let's focus a little bit more on this palmitoleic acid, okay, or POA. It is a product of something called steryl-CoA desaturase. And that is, together, these are both markers, independent markers of triglyceridemia and abdominal adiposity. So again, what we see is the higher the 16-1 or palmitoleic acid levels, the higher the triglycerides. Makes sense, right? High triglycerides are coming, again, from that high carbohydrate consumption. And this steryl-CoA desaturase, or SCD1, is already independently been shown to be related to high carbohydrate diets and obesity. And once again, it's the steryl-CoA desaturase that increases the level of palmitoleic acid. So higher incorporation of saturated fats into VLDL triglycerides is correlated with insulin resistance and adiposity, likely reflecting accelerated hepatic de novo lipogenesis, just like we saw in that previous study. Just to reiterate again, this is the pathway that is where steryl-CoA desaturase converts saturated fats into palmitoleic acid. And one of the questions raised that we don't have a solid answer for is, could this be the way the body actually protects itself from the very high saturated fatty acid levels that can be caused by, again, carbohydrate overconsumption? So now let's take a look at an example here more clinically, real world, if you will, on this whole principle. And this is a wonderful study by the Shea Group. They've done a number of great studies looking at low carbohydrate and low carbohydrate Mediterranean diets. So this looked at the beneficial effect of a Mediterranean diet over a low fat diet. But again, it's not just a Mediterranean diet, it's a low carb Mediterranean diet. And again, we can see here in this cartoon abstract, and I want to point out that there were almost 300 participants in this trial, that we have 2 arms, again, in this randomized control trial, Mediterranean low carb and low fat. And what happened is that the Mediterranean low-carb diet arm led to a significant decrease overall. This didn't break it down by saturated or mono or unsaturated, polyunsaturated fats in the liver, but a significant decrease overall in hepatic liver content, which they equate, correctly so, to decreased cardiovascular risk due to, again, decrease in insulin resistance in the low carbohydrate diet arm. So why does it matter? Why does it matter if we equate high serum levels to high saturated fat intake? I mean, because it sounds good and seems to make sense. Why do we care what it really is? Why do we care what the science is? Well, I just wanted to point out a couple of examples here in the literature when they missed this connection. And it matters. It matters a lot because, again, the premises of what we're recommended and what we're told to eat really depend on these trials, and these trials mess it up. So here is a trial, and I would like to read the very first sentence in this paper. Serum fatty acid composition is a consequence of dietary fat, but also of endogenous fatty acid desaturation. So it's a consequence of dietary fat, completely ignoring all the data that says contrary, but also endogenous fatty acid desaturation. So right there is acknowledging, yes, saturated fats are desaturated into palmitoleic acid, okay, but they've got the reason for this wrong. So fatty acid composition in cholesterol esters has been associated with insulin resistance and cardiovascular disease. This fatty acid pattern is often characterized by increased proportion of saturated fatty acids and 16-1 or palmitoleic acid. But again, tie it back to the very first part of the first sentence. They say this is a consequence of dietary fat. Again, as we already saw, plenty of literature to the contrary. So here this is, again, more from this study. So this was a Swedish cohort from the Uppsala longitudinal study of adult men. There was over 1,000 participants, and basically they measured cholesterol ester fatty acid composition at age 50, and then C-reactive protein at age 70. And what they found was that the increased levels of palmitoleic acid and SCD1, once again, is what converts saturated fat into palmitoleic acid, at age 50 was associated with increased inflammation via examination of C-reactive protein at age 70. It matters because it matters where the levels that were present at age 50 are coming from. And this paper incorrectly blames consumed saturated fat, of course, without any consideration of the dietary matrix, what was consumed along with it. If it was a high level of carbohydrates, once again, that's what's triggering the high levels of serum saturated fat and the high levels of serum palmitoleic acid. All right, so this is another study taking a look at, again, inflammasomes, the NLRP3 inflammasomes. And basically this is saying a high-fat diet induces the NLRP3 inflammasome pathway. And so, of course, then saying this contributes to insulin signaling and key targets, and this is all caused because of a high-fat diet, right? High-fat diet activates the NLRP3 inflammasome pathway, except for, let's skip ahead, it doesn't when it's consumed, again, with the background of lower carbohydrate consumption. We know that actually inflammatory markers decrease with low carbohydrate but high-fat diets. We have tons of clinical data on that. But here are two studies that actually show and discuss the basic science. Actually, beta-hydroxybutyrate, which of course comes from a low-carbohydrate, high-fat diet, blocks the NLRP3 inflammasome. So they're completely wrong with this presumption, completely wrong. And this literature exists. It's there. They can access it. But we once again see study after study equating the increased level of serum or plasma saturated fatty acids with an increase in consumed saturated fat levels. When we look at any of these studies, especially when they are rodent studies, it's always, and the headline is always blaming the high-fat diet. But I encourage everyone, if you read something like that, go in and see what the chow was. Because yeah, it's high fat, but it's also high sucrose as well. Why does no one stop to think, oh yeah, I heard sugar might be bad, that could be the cause? So in conclusion, we actually don't know what causes insulin resistance and metabolic disease. We need to find out. And the misinterpretation of what is the cause of some of the saturated fat levels in the serum or plasma come from, or the source of those, is one of, I see, the big blockers in us progressing on figuring out the answer to what exactly causes insulin resistance. There are many indications that serum or hepatic saturated fatty acids are causative to insulin resistance and and metabolic disease. But consumed saturated fat and serum or stored saturated fat are not the same thing in the context of carbohydrate restriction. Increased palmitoleic acid may actually be an early warning sign of diabetes risk. And once again, as we discuss, associated with a lot of problems: obesity, metabolic disease, and increased risk for cardiovascular disease and inflammation. So thank you all very much and have a great day.
Sarah Hallberg is always inspiring. I never get tired of listening to her talks. Very smart lady. Really interesting stuff about plasma fatty acids, in particular saturated fats, in particular POA, palmitoleic acid, if I get that right. I mean, should we be measuring these specific fatty acids in the plasma routinely, or does it tell us? Does it help us with our management?
Well, I mean, look, I always find these kind of things academically useful, but I don't know that it will. I'll learn something new from it. I mean, there's a lot of other easy blood tests that are routinely done that we can use for surrogate markers of poor metabolic health. I think it is incredibly valuable to understand the mechanisms by which it happens, but I don't know that we need to routinely test it. When I say that it's important to understand how it happens, obviously if we have an increase in the serum saturated fats in our blood, then somebody who may not understand the mechanisms could look at that and say, well, that's associated with poor metabolic health, therefore you shouldn't eat saturated fats. And I'm almost certain that that's the reason a lot of people have drawn the conclusion that saturated fats are bad for us, because an elevated level in the serum is bad for us. But as she very lucidly was able to demonstrate, it's not the saturated fats in our diet that drives the saturated fats in our blood higher. It's the carbohydrates in the diet. And I think this understanding, which is done a very nice job of communicating, will lead people to have a degree of comfort that, sure, you can eat saturated fats, just go easy on the carbs, the sugar, and the vegetable oils.
It's a very hard task convincing people, isn't it? I mean, I think we've almost convinced people that their serum cholesterol is not related to the intake of cholesterol in your food. Whether or not we can do the same with saturated fat, we've just got to keep producing the evidence.
I think it really comes down to the concept of what I call face validity. And it's something that if you look at it, it makes instinctive sense. And I mean, we have this all over. It's like if you eat fat, your body will get fat. That just makes logical sense until you understand that the body is incredibly inefficient at converting dietary fat into stored fat. You know, you think if I eat saturated fat, the saturated fat in my circulation will rise, until you understand that is not true. So unfortunately, a lot of people have a base understanding, and their understanding is probably insufficient and it means that people draw conclusions that are absolutely not justified. And if we actually, more people had more of an in-depth understanding of the science, as does Sarah, then we wouldn't be in this mess that we're in today.